Good evening and welcome to the RowanSOM Alumni Association's monthly webinar series. I'm Dean Michichi, Assistant Dean for Student Programs and Alumni Engagement. I want to share and extend best wishes to our panel and attendees from our Dean, Dr. Thomas Cavalieri, who was unable to join us tonight. We are pleased to bring you the March installment for our alumni webinar series tonight. This evening, we'll revisit a program we held last July entitled Surviving COVID-19, a Physician's Perspective, with the same panelists from that lecture, and as well as an expanded panel to explore the long-term effects of COVID-19 a year later. Tonight's webinar, entitled Surviving COVID-19 Long-Term Symptoms and Treatments, will feature an update from our panel about what they've endured the last year and residual symptoms they continue to experience. We've also added panelists for this talk, including a RN nurse and producer who will share her personal story, and a neurologist who will discuss the neurological conditions and consequences that may result from COVID-19. We hope to learn much more about the long-term COVID symptoms, treating options, and resources available for post-COVID symptoms. The format of the webinar series will include a moderated panel, followed by Q&A from our attendees. And for tonight's program, we've allotted up to 90 minutes due to the scope of this emerging and complex medical topic. As a reminder, you may submit your questions at any time in the chat so they can be shared with the panelists during the session. It is now my pleasure to introduce our presenters and participants, and I'll try to keep this brief to get our program started. In alphabetical order, we're going to go Dr. Shaila Bokkala-Pinninti, RowanSOM class of 2004. She serves as the Director of Neurology at Inspira Health System in Mullica Hill, with special interest in movement disorders and stroke. In addition to her DO degree, Dr. Bokkala-Pinninti has earned a PhD degree in biochemistry and has many publications and presentations to her credit. Dr. David Bollard, RowanSOM class of 1986, family medicine physician and partner with Premier Health Associates in Sussex County. Dr. Bollard is the president of the New Jersey Association of Osteopathic Physicians and Surgeons and the vice president for the RowanSOM Alumni Association. Dr. Ashgan Elshinawy, RowanSOM class of 1999, a pulmonologist and sleep medicine specialist who runs a medical practice in Middlesex County, Pulmonology and Sleep Disorders of New Jersey. Dr. Elshinawy is a RowanSOM Alumni Association board member. She leads the Alumni Webinar Advisory Committee and will serve as the moderator and a panelist for tonight's talk. Ms. Victoria Fredrick is the owner and independent producer for COVID Compliance, which helps film sets create a COVID-free environment. Ms. Fredrick received her BSN degree from Rutgers University School of Nursing in Camden and has 17 years of experience in entertainment and 10 years in lactation and nursing healthcare. Dr. Troy Randall, RowanSOM class of 2003, is a board-certified cardiologist at Lourdes Cardiology South Jersey Heart Group and program director of the Cardiology Fellowship at the Rowan University School of Osteopathic Medicine. Dr. Randall also serves as an educator for medical students, interns, and residents, and serves as a member of the board of the RowanSOM Alumni Association. And lastly, I am pleased to introduce student Dr. Debbie Meskin, a member of the RowanSOM class of 2023, who will assist with tonight's program. Panelists, thank you for lending your time and expertise this evening to address this important topic. I now hand off the program to our moderator, Dr. Ashgan Elshinawy.
Good evening, everybody. Thank you, Dean, so much for the introductions. I wanted to welcome everyone who's joining us tonight. Thank you for taking some time to participate in this very important discussion. I am so happy to be with these wonderful colleagues, some of them for the second time to revisit their story almost 1 year later, to see where they are now. And I'm hoping the purpose of this webinar is twofold. One is to inform everyone about this syndrome called long haul syndrome or long COVID. There's been a lot of names given to it. And it's basically people who have residual lingering symptoms related to the COVID infection long after the infection has supposedly cleared. So we're talking symptoms that are lasting longer than 3 months. There's more questions than answers, unfortunately. However, the second purpose of this webinar is to hopefully give some answers. And it's to allow people to realize that you're not in it alone. There are a lot of people with you. You're in good company. And to, again, hopefully support you and give you some answers to your questions. So without further ado, because we have a lot to cover, I'd like to introduce our first storyteller. So Dr. Troy Randall, if you can, please start us off and tell us how long ago you were diagnosed with COVID-19, how bad did it get, and fast forward to March 2021, how are you doing now?
So it's coming up on a year anniversary, so not quite a year. I was the end of March, I think March 26th, March 27th was when I was officially diagnosed with COVID-19. And, you know, initially it started off with headaches, fevers, body aches, loss of smell, which I didn't notice initially. And then the first week or so was the most troubling week. You know, I had the roller coaster ups and downs. And then I seemed, at least I thought I was getting better, only to find out 2 days later, this headache was coming back. And the difference between the headache the second time around versus the first time around was Tylenol and Motrin would not relieve the headache. So come to find out that I suffered a cerebellar stroke subsequent of COVID-19. At that point in time, we were learning about the hypercoagulability states of COVID. Strokes, very rare, but it seemed like most of the people that had suffered from them were younger, not necessarily having any other comorbid conditions, of which I didn't have anything to put me at risk of stroke. So, you know, threw me by surprise. You know, initially, you know, didn't really present the way that a typical cerebellar stroke would. So, you know, in terms of gait dysfunction, you know, I felt fine there, but, you know, the headaches, I had some fine motor deficit that was very subtle. And, you know, just knowing how things could have been the outcome, you know, I was, you know, thankful, you know, I could take the fine motor deficits. But then as time progressed, you know, we want to fast forward, you know, moving on, you know, this fatigue, you know, I think, you know, we're constantly going and, you know, don't necessarily kind of realize, you know, we used to like, you know, running on all four cylinders, and, you know, I would just come home at the end of the day and just, you know, pass out. Never happened to me before, you know, and it's just, you know, randomly, I can just be sitting on a couch, or I can, you know, even be in the office late afternoon and just, you know, all of a sudden, you know, get hit with fatigue and can't explain that. I suffered paresthesias and some arm numbness as well. I still have some difficulty when I try to do things, especially above my head. I tend to compensate for it. And one of the things that I hear all the time is, you look great, right? So, you know, people see me and they say, you look great, but don't necessarily understand like kind of the day-to-day symptoms I have, or what I experience when I kind of go into my own little bubble away from everyone. You know, I think, you know, in healthcare, you know, still somewhat try to be stoic. So the biggest things that I still experience are random fatigue, and there's no rhyme or reason. You know, one day I can be fine, the next day I'm running out of gas. I still have some of the numbness and paresthesias, although markedly improved from last year. Still residual with that. And I think the biggest thing that seems to be amplified more so when I wear my mask than, kind of being out and about openly like I am at home right now is, kind of this brain fog, right? So, I could take my pulse ox and my pulse oximetry seems to be fine, but I still have this mental fog when I am wearing my mask for a long period of time.
I'm very sorry to not only hear that you tolerated that a year ago, but that you continue to have pretty significant symptoms actually a year later. How has it impacted your life on a personal level, if you don't mind sharing, and also on a professional level with your work at the hospital or the office?
Easier to start professionally. So professionally, I'm working in the office, outpatient only right now. I'm not back in the hospital, and a big part of that is the symptoms I'm still experiencing, and concerns with liability and patient care. Not quite being 100% able to do that in an acute care setting. So I think I feel very comfortable outpatient wise because I can take breaks as needed. The other part of that, in the outpatient setting is I have control over my schedule, which is difficult in an acute care setting in a hospital. So professionally, I think I've been able to adapt that way. Over time, I've increased my hours, so I'm back to being able to work a full work week. Initially, I did not have the stamina for a full work week, but I think that I've developed that over the last year. The difficult part to that question is personal, and 2020 I think was one of the most difficult years I've had personally, and part of that is throughout my life to be where I am, especially as a minority, I've had my struggles. I've had humbling experiences and all, but to be in a situation where you weren't sure if you were going to survive, I think puts a different aspect of things, and that sense of vulnerability. I don't talk about it a lot, but mentally, I think it was probably one of the toughest years that I've ever experienced. I think it's tough to be feeling what you're feeling, and again, as I mentioned, when people talk about how great you look, but not feel how great people perceive you to look is difficult as well. And mentally, if I had to say, I'm still struggling with that somewhat, but I feel like I'm in a better place than I was maybe 3 or 4 months ago with that. One of the things I think helped me was learning about COVID long haulers and starting to see stories and seeing other people that were still experiencing these symptoms months thereafter. And it's like a little reassuring, this is not in my head. What I'm feeling is real because other people are feeling it. And that's another thing as a healthcare professional that's difficult, right? So, as a physician, we try to take care of our patients. We feel that we're listening to our patients, but sometimes, we don't always have an answer for our patients. And it becomes difficult when I know what I'm feeling, but my symptoms don't necessarily correlate with what you suspect from a CT scan or MRI scan, but yet it's real to me. And how can I explain that? So starting to see more light about COVID long haulers, I think has helped me mentally over the last few months.
Troy, I really want to thank you for being so honest and open, because it not only it enriches this webinar, but I think you are probably connecting to a lot of people out there that are too afraid or embarrassed or to admit that they may have suffered with anxiety, depression over an illness. And it doesn't have to be COVID, it could be anything. And I think specifically as a physician, we have this added pressure to be invincible. We're not allowed to get sick, you know, in anyone's eyes, I think, especially our own eyes. I mean, God knows when I call in sick for any reason, I feel so guilty. And I know some of my patients who are on these on this webinar, I'm sure can attest to that. I always beat myself up when I take a day off, and I can't even imagine what you've been through, but I really appreciate you sharing a small piece of it with us today.
Thank you.
And I'd like to, I mean, I have so many questions for you, but we could definitely come back to it. But I wanted to ask actually our neurologist, Shaila, if you wouldn't mind, how often are you seeing these long-term symptoms, neurological symptoms after COVID infection, specifically stroke initially, and then long-term, the fatigue, the headaches, and maybe mood disorders?
Well, the key thing about it is the variability, very variable, and like Troy was addressing, it's very fluctuating too. So I've seen headaches lasting for up to 6 months. The frequency increases as well, like people who have had migraines before, they were sporadic probably, now they increase, become more frequent. But more importantly, the paresthesias and the burning dysesthesias, and I think we can attribute that to the vasculitis. There's a cytokine storm, the surge of it, and causes that. And so also, if you look at the MRI, and the fogginess comes from that because you see these white matter changes. We call that a leukoariosis. So you see in basal ganglia, internal capsule, you can see it in the midbrain too. So this kind of impacts, I think the mental fogginess is because of that probably, but there's actually NIH has approved a 1.5 billion grant to study these long haul of patients for a period of 4 years. Because right now what we have is just correlation, but actually a study dedicated to the follow-up of these 4 patients, how long the patients last, how long the symptoms last for these patients is something that needs to be studied, I think. Right now we treat only the symptoms. There is really no fix per se. You treat the symptomatology, but autonomic symptoms are seen too. You often see postural orthostasis and tachycardia symptom as well. I'm sure you must have seen, and Troy must have seen as well. So the symptoms in some patients last as much as 3, but then the fatigue can overlast. And the unfortunate thing is there's no physiological pathological correlate. So it's like almost you say chronic fatigue syndrome or you say fibromyalgia. There's nothing to really gauge. So that's why there is a disconnect. I mean, it's not, your appearance is not commensurate with how you feel. Like Troy was emphasizing on that. You look good, but you may not feel good. So there's like a mismatch.
Sorry, and if I may ask, picking your brain, no pun intended, you're a neurologist. I had read recently that behind the brain fog for a lot of these post-COVID patients, and also clotting mechanism behind maybe clotting strokes. I'm reading that in post-mortem, God forbid the person dies and they do an autopsy and they dissect the brain, they actually are finding what's called megakaryocytes. And for those who are not clinical healthcare workers, they're precursors of platelets. And so there's like this process, we think that where inflammation is so bad, the viral infection is so bad that it's pushing out these precursors from the bone marrow, crossing the blood-brain barrier, getting into the vessels of the brain and causing this mental fog and possibly strokes on rare occasions. You read that.
And microbleeds as well. That's what it causes, is the microbleeds. Tiny little hemorrhage, petechial hemorrhages as well. So yeah, the excessive amount of cytokine surge, like the IL-6, which are the bad ones, the cytokines can't handle, and that's how you get the megakaryocytes leaking out from the bone marrow into the bloodstream, crossing the blood-brain barrier, like you mentioned, and you find these on the autopsies.
Mm-hmm. It's very fascinating, and I know
as we speak, like, Yeah, it is evolving as we speak. I think the more we learn, the more we learn about it, the more, you know, we get to know about it.
Right, and just to kind of frame it with what we know in terms of the data out there for all our attendees, it post-COVID syndrome and specifically fatigue and muscle weakness is found in about 60+% of patients who recover from COVID. And in terms of anxiety and depression and mental fog and everything, that's present in over 20% of patients. So these are substantial numbers. And as Shaila was alluding to, the NIH is going to be spending billions of dollars to research this, because I think this is data that'll be coming, you know, for years. But it's affecting a lot more than I think we know about. So I'm really glad we're at least having this conversation to begin with. Okay, Troy, we're not going to leave you forever. We're coming back to you because it's extremely fascinating and just so wonderful for you to share with us. But I'm going to move on to the next panelist because it's not a 5-hour webinar. I wish it was. But so I want to next go to speak for myself, right? I want to go to Dave. Dave, same question I asked Troy. When were you diagnosed? How bad were your symptoms? And where are you now?
All right. First thing is, I'll tell you, when I feel down, which I still do periodically, I think of Troy, and it actually helps me, because I know I'm not like the only guy, you know. And it's actually there's some comfort in our pain, I guess. I don't know. That's kind of sick, maybe, but it's true. So thanks, Troy. You helped me out. You may not know it, but I think about you often. So Thursday tonight is 2 weeks and a year since I got sick. I was early, March 11th or something like that, pretty early in the game. And I was pretty sick, and I was sad at work for a couple months, and slowly worked my way back. And I would say, like, for me, it's pretty much a systemic illness for me. I had gastrointestinal symptoms. I had a lot of respiratory symptoms. I had some sugar issues that I'd never had before, and then the mental fatigue. And all of them kind of were pretty bad at different times. The worst part for me now is that fatigue, which I used to be able to do 12 hours every day at 60 years old without a problem. And now I find as the day goes on, I start getting pretty tired. And it's a new experience for me, because I'm saying, well, is it just because I'm older, or is it not? But I definitely, if you ask me February of 2020 and April of 2020 or this year 2021, there's a big difference in how I feel and how I handle things. So I don't do as much. As president of the state association, I'm stepping down this year because it's just a lot to do. I was the president of my medical group, and I stepped down from that and focus, like Troy said, just primarily on the office, because when I do get tired in the office, I can take 10 or 15 minutes, and that actually really helps, I find. And the best way I can explain it is to get from point A to point B used to be for me a straight line. Now sometimes it seems like I'm trying to find a new path to get to that point B. And I can almost feel it. I'm going to get to the right place, whatever that is, how to treat whatever, what the name of a drug is, when my wife's birthday is, whatever it is. But sometimes I might not take the direct path. I have to think about it a little bit. And I can almost feel my brain trying to find another way to get there. It's a strange sensation if you've never had it, but I actually have it, and I've learned to like experience it and work with it. I still feel like I'm sharp, but I'm sharp at a slower rate than I was in the past, if that makes sense. To help that, I put breaks in my day. I cut down the amount of things I do aside from working, and I also started doing things like chess. Started a computer chess and building myself up into the levels, playing the computer at a harder rate each week until it starts beating the hell out of me. Then I back off a little bit to get my confidence back, and then try to move forward. My asthma is worse. I had a little bit before that. My stomach, I'm afraid to fly with my stomach now, but I fly anyway when I have to. And my sugar, I have to really watch my blood sugar now, which I never had to do. February of last year, my sugar was 108. March of last year, it was 250. And I hadn't eaten 3 or 4 days at a time because I was so sick. So something happened. And now, you know, if I don't watch it, it'll be up. If I watch it, it's 110 to 125, somewhere in that range with work. So that's where I'm at. Emotional, physical, combination of the two. I think the psychological part is there. There's definitely a stress. I use these kind of situations where we're talking today. It helps me. Thinking about what Troy's going through and that we're not alone doing this thing, I think helps. And I think there is that emotional component, and there's also a physical component because I can feel it. And that's kind of where I'm at. I feel better than I did last year for sure. I feel better than I did 6 months ago, but I'm still not where I was February 2020. That's it.
Thank you, Dave, so much
Yep.
for sharing that with us.
Yeah.
I really love that you've taken up chess. I think that's a really smart thing to do. And it's trying to find a solution to try to stimulate the brain. I don't know a better game for it, honestly. And if you're into video gaming, I have a 19-year-old that will take you on for sure. So just hold your mental fog.
You know what's funny is I'm playing, and I used to play a lot better, obviously, but I hadn't played in years. And what I've noticed is I do stupid moves. And then I'm like, what the hell is wrong? Come on. And then like 2 days later, I'll do the same thing, you know, and I'll be like, oh, Jesus, what is that all about? You know, but it's becoming less frequent, and I'm moving back up the ranking of the computer, but I'm nowhere near Grandmaster Dave, as they say, at this point.
That's quite all right. That's quite all right. I wanted to ask Shaila if would you recommend anything specific for people kind of battling what Dave is talking about, the mental fog and the focus at certain times, trying to complete a task without having to go through certain steps? How do you, besides measures that he's already taking?
I agree with him. Taking breaks would help, and planning out, being more methodical, I guess, would help, just so that you're focused on that. But also, like, he took up the chess game, which is very intellectually challenging. That's a great idea. There is something called a www.lumosity.com. There are like grades of exercises where you could start at a lower level and gradually increase. That would help. And taking breaks absolutely could do as well. Sometimes actually it helps taking a pause to formulate. I'm sure sometimes you may not get the right medication right, just like you used to get it in the past. So if just you can formulate your thoughts a little bit, and I think that comes in eventually. But these symptoms actually gradually resolve, though, you know, in about 3-6 months would definitely do that. And same thing with you know, people say exercise intolerance after that. Again, you know, you can't just plunge into it. You could just have to ease into getting back to your exercise.
Yeah.
Okay, thank you. And I'm actually going to ask Dave and Troy a question, a follow-up question, and it's inspired by my prior classmate who is chatting up a storm in our chat room. I'm going to embarrass her, Dr. Tamburello, who is a very wise classmate of mine. She said the psychological effects are amplified by the relative isolation of the pandemic situation in general. And I think that's an excellent point. How much do you think that's playing a role for you, David and Troy? David, you want to start?
Well, I mean, I'm a social guy, man. So this is killing me. I mean, before this, we would go out every weekend. We would go to dinner with people, play music in clubs. I mean, my whole life has been social. So I hate, even at work, everyone's wearing a mask and I have to kind of stay in my office. I want to like hang out with my staff and joke around and laugh like we always did. So I feel that. I feel that bad. You know, I'm not alone with that. I know everybody has that. I mean, I'm treating every third person I treat has got some anxiety now that I see on either in the office physically or whatever. But I think we're social animals and we're not used to being like this. You're semi-caged. We don't like it. And I feel that. I don't know what anybody else feels, but I see it every day in the office, the people I'm talking to, you know, on the phone or if they're in, and I'm feeling it myself. When we were sick really early. People were afraid of us. So we were really isolated. I mean, when I said I didn't eat for 2 or 3 days, we ran out of food because we were too sick to realize we didn't have anything and people were afraid to come over. And I was too mentally messed up to ask for anything. But so, yeah, it's definitely real, you know. I think getting everybody back together and getting them immunized is a really good plan. It'd be good for our collective mental health.
Absolutely. Troy, what do you think?
So I agree that does play a role and amplify things, but I don't think it impacted me much. I think I'm very social, but we have a blended family and 6 kids all together, so we still partied, and I still had a lot of interactions just being in my home without getting out with others. So I definitely had a lot of engagement going on during that period of time, and I don't think I had to fear to isolate myself as much. Kind of having COVID, and even now with the vaccinations, if I needed to travel, if I want to go somewhere, I don't have the same fear as someone that may not have had that exposure. So I don't think that myself, I was as impacted by isolation.
Okay, well, that's good to know. Definitely.
My kids are grown up, so we're by ourselves now. I wish I had 6 kids in the house. It'd be awesome.
Again, I'm offering up my 19-year-old. Please accept.
That.
Okay. All right.
You're on your own with that, my friend. Been there.
I know. I wanted to, because Dave, you touched upon this just briefly when in your last statement. What do you say to patients or friends, family members who to this day are reluctant to get the vaccine?
So it was a lot worse, that conversation in December. It seemed for a little bit of time in late December and early January that the anti-vaccination crowd was going to win the day. And I was very nervous about that. I'm not so nervous about it now, and maybe the fact that it's been a little bit undersupplied made people like want it, and it seemed that now there's a little bit of that frenzy, like, well, I want to get it. Why can't I get it? I should be able to get it. I have hypertension, and I'm 65 years old, and so there's a little bit of that, which I think helped. So I looked at the science of these things. I know I'm an old FP, but I actually read, and I read the studies, and the science was awesome. And I was a biochemistry major back before there was anything but agar plates and stuff like that. And so I understood it. And I would say to these people, there are people who are infinitely smarter than me, who are telling you to get this vaccine. I'm smarter than you. This is what I've done my whole life. And I've read the studies, and I've listened to it on the internet. I actually read the data, and I'm telling you it's safe. Now, you're going to believe me or not, but if you don't believe me, then you should probably hire somebody else, because you're paying me to read those studies. And there was some pushback, but there wasn't as much as you would think. And every question that they would have, I would try to have an answer, like, well, my DNA. And I would say, well, it's an RNA. It doesn't get into your nucleus, so it can't really affect your DNA. That would need reverse transcriptase, and it doesn't have that. And so I'd hit that. Or is there a transmitter in there that's going to follow me around? And I would say, this is called a cell phone. This is how the government could follow you if they wanted to. They don't have to put it in their vaccine. Or they would say, can it hurt my eggs? And I would say, well, it doesn't get into your eggs. It gets into your cells, but not into the DNA, so it's not going to change your eggs. And I would go through everything that they would worry about and have an answer for them. And I made a nice video for a practice that got like 5,000 views of why you should take the vaccine. And people were good with it. They said, all right, we're going to trust you. And then they couldn't get it. So it actually helps. I said, well, see, you missed out. You should have gone online sooner. Oh, yeah.
Thank you, Dave. And I did see your video. I really appreciate you taking the time to do that. That was really appreciated.
Thanks.
Troy, I have a question for you. Do you notice a hesitancy in the African American population among your patients or family members?
I do. Before I answer that question, I have to say, wonder why, Dave and I have gotten along a lot. I was a biochemistry major as well, so I never knew that until he just said that. So, but I have noticed that, and a big part of that is because of trust. I think that there is, issues with trust as well as fear in the community, and one of the things that we didn't do well last year was talk about the science, as Dave mentioned, talk about the safety profile. And there's a big feeling that all of this was politicized over the last year. So, a lot of times when I have these discussions, I am very open and honest with them that if, we were having this discussion last August, September, I will probably be right along with them saying I'm not getting the vaccine because, we weren't talking a lot about the safety and the data. But, as we learn about that and we look at the safety profile of the vaccination versus the risk of COVID and the kind of those outcomes and also addressing those fears of the unknown, like, being honest, I don't know how long this will protect me for, but I know I have some protection. So I think that as I start to really address the concerns that they have, I find most of them to become receptive. There's still a number that even after you discuss with them are hesitant, but I think that they've become a lot more receptive after kind of hearing that angle and establishing some of that safety measures with them and addressing the fear. I think a big part of it is trusting the government, trusting the physicians and trying to get over that. Even from religious standpoints in the churches as well. Are we like kind of implanting chips? What is it that we're trying to do? From a mass vaccination level. So I think rather than using social media and saying you have to do this, I think we have to do a lot more educating, and people are more receptive at that point.
That's wonderful. Thank you so much. And I would like now to transition. Victoria, don't get, no, you're up now. Get under there. I want to present our last storyteller. But before I do that, I want to say that it's important that we have a woman on our panel because COVID-related complications we have found affect women more so when we're talking about the long haul syndrome, especially if they had severe COVID. And Victoria was no exception to that. So I would like for Victoria to share with us, if she would, when she was diagnosed and how bad was it for you, and where are you now?
So my anniversary is today.
Oh.
I got my COVID on March 24th last year. It was, at first I was going to manage it at home. I had your support. I had my primary care support, and we were going to do the whole thing at home. I'm a nurse. I have my SpO2. I have my stethoscope. I have my blood pressure cuff. I know my fluids. And then I went to the hospital on the 30th of March for fluids. And then I got a Z-Pack and I came back. And then after that, my husband kept track in like this little book. And after that, the writing changed. It's no longer my writing, it's his. So on the 4th, they took me to the hospital. I don't really remember. But weirdly enough, my SpO2 was still 96. But I was not lucid. So I was in the hospital until April 16th. I came home on 3 liters of oxygen and I beat it. Went back 3 days later with bilateral pulmonary emboli, and I was in the hospital to the end of April. Came back home on 2 liters. I was better with the oxygen, on anticoags for 6 months. And then I went back in the hospital May 10th, mini stroke. And I was in there for 2 days. It was very light. They said it's a TIA, but then later in the year, my optometrist found that I had, I think it was low oxygen in my optic nerve. So it was really a stroke. And that's one of the things I'm left with, word finding issues. In between, I had issues with my blood pressure. It go up, they go down, they go up, they go down. I had right side heart strain. I had syncope. My heart rate would go down, and I lost my driving privileges, which is a great impact on your life, for 6 months. Then let's see, I had PT. I had a speech pathologist who came, and they said they really couldn't give me any speech pathology because my norm was so far ahead of other people's standards. The insurance really wouldn't pay to bring me back to what I was supposed to be. Let's see, I came back out, I was doing really well. And then I got my COVID shot and got another PE, and I'm back on PT twice a week for gait therapy, and I'm back on coax. So right now, I'm doing better than I was last year. I feel better than I did last year, but I'm still on blood thinners. I can drive, but I still have problem finding words, which is really a pain. And I have no core strength, is what they say. So anytime I walk for any amount of time, my back spasms.
Victoria, even though I know your story very well, I'm still floored by it. I don't know what to say besides that you are one of the strongest women I know, and you remain truly an inspiration to me because you do not give up. So just to summarize what Victoria said, just because she is too smart for her own good and she knows a lot of medical lingo, so want to summarize, since she got diagnosed with COVID a year ago, and I'm so sorry to say happy anniversary, I didn't even put it together that it was today, amazing. She developed blood clots in her lungs. She developed a minor stroke, and which may be due to blood clots, we don't know, or low oxygen level. She developed heart rate that was going up and down. She developed syncope, which is the word for passing out. She was not able to drive. She was very, very weak. She really wasn't able to work for a very long time. The mental fog definitely was illustrated there. And then recently developed another blood clot. We can discuss that too if we want. We have some theories about that, but we laugh because we have to laugh. We've shared a lot in the past year together, and we have to laugh in order to move on. Yeah, but you survived it all, and so I commend you for having such a wonderful attitude. And I think Dave and Troy are both floored by your presentation and saying, "Oh, well, we weren't so bad after all."
Nice. Thank God, man. Ashgan, was there any vascular issues with your friend prior, or is this all post-COVID, like clotting? Or
Post-COVID. They
Post-COVID.
even sent me to a beautiful hematologist to make sure.
Yeah, because it just seems like amazing that you would get that prolonged, you know, after the illness and have clots and strokes and PEs. And good golly, thank God for you.
They called me a zebra.
Yeah, right? Yeah.
Beautiful zebra. But yeah, no, she had no vascular issues at all. It was just asthma, plain old asthma. That was our biggest issue, right? For years. And
That's right.
Post-COVID, it was, you know, totally different animal. Yeah, but I have it, and I think, David, you bring up a really good question. And Victoria's presentation over the past year, as I was taking care of her, I was trying to think of why COVID affects different people differently.
Mhm.
You have some people who get COVID, walk around and don't know they have COVID, and they're spreading it like wildfire, the asymptomatic crew. And there are people who are homesick for a week or two and then get back into life, no residual symptoms. There are people getting strokes and blood clots and on ventilators and lose months of their life, literally. And there are people who die. And it's the same infection. So, you know, I was thinking so hard about this for especially the first few months of the pandemic, because I was puzzled, and I think we still are a little bit puzzled, but we have more theories and working hypotheses out now. And we think that a lot of it has to do with the immune system of each individual person and the propensity for the immune system to go wacky, crazy wacky, meaning it just responds a little too far in trying to kill this infection, this foreign body. And so a lot of us clinicians know this as an autoimmune disorder. So I'm not saying necessarily you guys have an autoimmune disorder, but that's just one theory, you know, where people like have lupus or Lyme's disease or scleroderma or rheumatoid arthritis. Those are examples of illnesses where the body forms antibodies against your own healthy tissue. And when you get the COVID infection, all these cells and antibodies just rise up to kill this virus, but then somehow get redirected to stay on and start attacking normal tissues long after the virus has been killed. And my other theory that I have, and this is not proven, of course, and I don't know if it ever will be, is that I wonder if for some of this long haul syndrome patients, is it because there are still trace virus particles like hiding out in certain tissues or organs in our bodies? I mean, the example that I can use to compare with is shingles, zoster, chickenpox, varicella. So everybody knows those terms, and the virus doesn't go away, right? We all know that the virus, once you've gotten herpes, a sore, cold sore, it's always part of your nervous system, right? It just hibernates a little bit. And as I'm sure Shaila can, attest to, is, we're recommended to have the shingles vaccine, I believe in our 50s, right? To prevent shingles. And it's not to prevent the infection, it's to prevent the activation of the virus that's probably in all of us, because we've all had chickenpox pretty much. So I'm thinking it's something very similar to that, or Lyme disease, where the pathogen is way gone maybe, but the autoimmune system is still there. So just some theories we're throwing out, because I get that question a lot from patients, like, why did this happen to me? My cousin got it and is, didn't lay in bed for a day. So we're all made very, very differently, and our responses are going to be differently, just like our responses to vaccines have been quite different, as we saw with Victoria too. So, okay. Now, Shaila, did you want to add anything about Victoria's presentation, the fact that she had a TIA and still continues with the word finding issues literally a year later, and what she can do?
I wonder what the TIA symptoms were, Victoria. What were your symptoms when you were diagnosed with TIA?
So I had facial numbness. I had left arm. My left arm was weak. And then when I got to the hospital later, I had ataxia on my left side. So I couldn't raise my left leg at all. But by 36 hours afterward, I could. Not to the same degree, but like so 2 inches up.
So you essentially had some sensory and motor symptoms all on the left side. So you had numbness on the left side of the face, and then you had some motor deficits on the left side.
But they all were gone by 48 hours.
Oh, okay. Did you have any acute confusion?
No. Matter of fact, before I went to the hospital, took a gorgeous picture.
Okay. Well, I mean, when they did the MRI, did they find any kind of white matter changes?
They did an MRI. They didn't even see a stroke. That's why they thought it was a TIA. But actually, my optometrist later on, she had retinal scans. So I take a retinal scan every year. And when she took it, she saw the difference in my left optic nerve. And she sent that to my neurologist.
I see. So I think you didn't have a stroke. You probably might have had some white matter changes. Again, that's part of the whole spectrum of the release of these cytokines causing vasculitis and attacking the brain and leading these fine white matter changes. And they can also mimic TIA, but you probably might have had a stroke based on the OCT. I believe it is OCT, right? Ocular computed tomography, when they do their optic nerve. Yeah.
Mm-hmm.
So.
And a gait change.
Yeah, this is all attributed to actually vasculitis. It is a huge cytokine surge, and that causes vasculitis, which in turn causes the strokes. And also, if it's not severe enough, that's what it leaves you with these white matter changes. And I think the white matter changes are the ones that are causing your word finding difficulty. Like you really have to fumble for the right word. You know what you want to say, but you just can't get that.
And I know it when it's wrong too. Sort of like what David said, when you know the word you want to say and you want to get to it, you just got to find a way to it. You just got to take your time because you know it's there, and every word that's not that word is wrong.
Yeah.
Is that getting any better, Victoria? The word finding difficulty?
Actually, it hasn't gotten better. It should have, but it has not gotten better.
Are you doing any exercises, anything to help yourself?
Yeah, but the exercises, to be honest, are not of a level that would challenge me. I mean, during the whole time that I had COVID, I finished my BSN.
Very impressive.
So they were not of the level that would challenge
But
me.
you know what? I have to say, if it was anybody else, I don't know if they would have been able to do that. It really depends on your baseline level of intelligence. And you've had a whole lot of it and you still do. So, but yeah, I think you will continue to improve because you have a great attitude and a great mind. So I think you'll continue to improve. Just got to keep working on it. I want to, Shaila, unless you had something else to say, I'm sorry to interrupt.
No, I think you can find exercises that are challenging and keep doing those. That will only get better. In 3 months, 4 months, you'll see what an improvement it's going to be.
Thank you so much. I actually have a quick question for Shaila. Do you think for symptoms that they're all really describing, if you think like the mental fog could be related to a possible vasculitis or something, is there any blood work or anything that can be checked to confirm this? And also, would they benefit from any steroids?
Yes, in the acute phase, there's called something as acute necrotizing encephalitis. You have the, if you look at the blood levels, you have the GFP, which is a glial fibrillary acidic protein. GFAP is elevated, then you have the light chain, the neurofilament light chain is elevated, and phosphorylated tau. But that actually comes down, it's in the acute phase in the first 2 weeks, and that's only in the sicker patients who actually were admitted, but not the ones who were at home.
Mm-hmm.
The treatment at that time would be IVIG, has been shown in limited studies, but limited number of patients, but IVIG infusions help them overcome the symptoms. Long term, there isn't any great way to gauge. That's why I think we don't have a good, pathophysiological correlate to measure long hauler syndrome patients. So we don't have anything. These phosphorylated tau, they all come down gradually. In the acute phase, they're all elevated. The neurofibrillar, GFAP.
I've been watching, I don't know if it helps. I've been watching my ferritin level. It was 850 or something in the hospital. And it still stayed elevated. It was 600 when I was home. Then I checked it again. It was 350. It's still around 300. It's high. I believe that's high, but it was really high, and it's been slowly drifting down. Trying to do things for inflammation, naturally, like olive oil and fish oil and things like that. Some natural anti-inflammatories, maybe some herbs. I'm having the same thing with the brain right now, so I do take some what is it, cinnamon and some other things.
Turmeric. Yeah, acute phase reactants. You're talking about the acute phase reactants, which is the LDH, the ferritin, the whole ferritin
Yeah.
And but I think what Ashgan was alluding was just particularly for the brain in the acute phase.
Yeah, well, I don't know about that. I just know that I still have brain issues and that's still high, so I watch it.
And Dave, that is a good point, because we really don't have too many markers to follow. And in fact, when I see my patients post-discharge from the hospital 3 months, 4 months out, and I see that they're having very, very significant persistent symptoms, that's one of the first things I do. I check the ferritin, the LDH, you know, those CRP, you know, those kind of inflammatory markers.
Yeah.
And at least it's not so much what the absolute number is where it is with respect to the trend, right? Because it tells me where they're going. And sometimes I do start steroids much later in the, if it's interfering with their quality of life, and I think I can improve their shortness of breath or their severe muscle aches or arthralgias for, you know, with a week, 2 weeks of steroids, and there's no risk of diabetes, I do try it. And it really has helped a lot of people. And we certainly are using it now in the hospital. And I feel like it's really saved lives. Steroids, we did not really use it at the beginning of the pandemic, and we are using it heavily now, and that's why I think we're able to discharge people a lot faster than we were a year ago.
What happened that made everybody stay away from steroids last March and April? Because I think it really caused a problem for a lot of people long term, and for a lot of the deaths, you know, that we intentionally didn't use them. I think that was a mistake. I mean, I couldn't understand it. When you can't breathe, every other illness, when you can't breathe, we put you on steroids. And then this one, they're saying, don't take any steroids, but hold your, you know, take a deep breath, but nothing's working. I was like, I need some steroids, man.
Absolutely.
Yeah.
And excellent question. I remember end of March of last year, I had that conversation on the wards when we were treating people on non-rebreathers, almost ventilated patients. And I'm saying, as a pulmonologist, I'm like, let's give them steroids, please. Yeah. And the infectious disease specialists who are on every single COVID patient case, also alongside pulmonologists, their argument was, and then, you know, it was a good one because we didn't really know, we don't want to suppress the inflammatory system, the immune system, and because that's what we need to kill this virus. We have nothing else to kill this virus. And if you give them steroids, they may become septic. And so it scared us enough, but you're absolutely right. We see life-threatening illnesses like tuberculosis and you know, other infections where we give steroids because the inflammation has gone hog wild.
I think there probably is a time, maybe the first 7 days, where you need your but then your immune system gets so revved up, it's probably overdoing it. That's what it seemed like, because most of the people who got really sick that I was treating later was day 9 and 10. And that's when they started to really, I think, you know, the first week their immune systems were doing what they're supposed to, but not winning. And then they get frantic and they start doing more harm than good. So I think that's probably when the steroids, I put them on at day 9, if they're not getting better. Day 10, I hit them hard then. Seems to help. I don't know. It's all anecdotal now. But
I was in the hospital at that time when they said don't use steroids. And I remember the literature that came from the WHO and the literature that came from the CDC specifically said not to use it. And it was that or event, and I wasn't going on an event. So that's when they decided to use steroids on me. And it was helpful, but they wanted to use the steroids because other things were not working, but proning helped a lot. So, because I had just come out of nursing school.
Define proning, Victoria.
Laying on your stomach to breathe the entire time. I don't think I laid on my back the whole time I was in the hospital until like the last day. So the whole time I was positioned on my stomach, my head kind of laying off the bed, all IVs and everything. So I could breathe better. It gives you better chest expansion and allows you to get more oxygen. So between that and then they gave me the steroids, 5. I remember emailing you. Is it okay? What do you think? What do you think? And finally go ahead and get me the steroids.
Victoria had a rebellious lung specialist who did not listen to the WHO and the CDC and started her on steroids. So it just made sense. You know, sometimes common sense has to win over when we're dealing with the unknown.
That's what I was saying. So
Yeah, I want to now turn over, because we're 8 o'clock and we're still going strong. I want to turn over to our student doctor, Debbie Meskin, to see if we have any questions from our attendees, please.
So we do have a few questions. The first one was really based on like the inflammation talk that we were talking about before. And they said that some of the long-term effects of COVID, especially the fatigue, are reminiscent of post-chemo and radiation for cancer, which may be inflammation-based. And they wanted to know if you guys could see a similarity between the two.
Okay, between post-chemotherapy and post-COVID?
And the long haul symptoms that they're having.
That's an interesting question. I mean, with chemotherapy and radiation, I believe it's a slightly different mechanism. If anything, we're actually depressing the immune system with chemotherapy. The only similarity I would say is that there are some chemotherapeutic agents, and certainly radiation one of the complications from those two agents or categories of agents is that they can cause inflammation in certain organs depending on which chemotherapy we're talking about. So they can cause pneumonitis, they can cause meningitis, they can cause nephritis. So that I'm just naming different organs in the body and adding an itis at the end, just inflammation of different organs. So in that sense, it's a similarity. But at the same time, chemotherapy does depress your immune system. So it's an interesting question because we really still don't know why COVID patients are acting the way they are or feeling the way they feel. Is it because of a depressed immune system, overactive immune system, overactive inflammatory system, or do they still have viral particles in them? We're still not sure. Interesting question.
Speaking about the uncertainty, the next question was the Johnson & Johnson vaccine is DNA based. Do you guys have any thoughts on the safety on that vaccine?
You want me to go? Okay.
No.
It's actually, did you just say it's DNA based?
It's a viral vector. So.
Yeah,
that's what the question said.
Oh,
yeah.
Okay. I just want to make sure I heard it correctly because it's actually not DNA based. It's the Moderna and the Pfizer are messenger RNA vectors. The best way I can describe the Johnson & Johnson is it's kind of like the flu vaccine in that they use like a killed form of the virus. So that's the phenotype that they're using. So it's not messenger RNA at all. It's not making your body make a protein. It's literally injecting you with a foreign particle that resembles the virus. And so that when your body is exposed to the real virus, the live one, it recognizes it from before and then quickly inactivates it. So it actually has no genetic relationship at all, the Johnson & Johnson.
And I could add to that maybe. I think part of the reason why it may not be as effective, 70 versus 95 is what I've been reading, is the fact that the viral vector they use to inject you, if you've been exposed to that in your life previously, some people think you may recognize it quickly, mount an immune response before you actually have an immune response to the particles. I guess it's the spike proteins in there that they put also. So you make those antibodies because you'll attack the vector before you actually have the immune response you want from it. So that's why some people don't get as good a response from the J&J as the messenger RNA, which to me seems like a better vaccine model.
And just I'm going to add on to what David added on to my comment. And I'm really glad you brought up the numbers because a lot of people are getting fixated on 95%, that's super high, And then 70-something% were like, why do we want, I've had so many patients tell me, why do I want to get a Johnson & Johnson when I could wait for the Moderna Pfizer, which is so much better? Because, and I tell them those two numbers are not apples and apples. So the reason why is because the 94-95% was testing against the original COVID virus that came out in Wuhan and came out to our country in December, January or so of 2020. And Johnson & Johnson came out much later and was actually tested against the new variants, some of the new variants that are out, including the one from South Africa, from Brazil, Spain. And so that pulls down that number because we know now all the vaccines are not as effective against the new very dangerous strains, but they are still effective, but not as. So you're not really comparing them fairly. So Johnson & Johnson may be just as good, if not better, against the new strains. We just don't know yet.
Yeah, I will add on to yours too, Ashgan. It has been actually effective for the real contagious one and the real sick people that's seen. So you're right. You can't compare these to the Moderna or the Pfizer only because they're being used against the most contagious one and also the sicker patients, and that's why it's 70%. But if you look at it, it probably would correlate much higher than that.
Absolutely.
I think with an mRNA, with an RNA-based virus, you're putting in an RNA, you're transcribing within your system to an mRNA, and then transcribing that into a protein. So you'll have much more of the epitopes that your body can form antibodies against, as opposed to an adenovector where you're putting a killed virus. So I think the amount of immune response you mount would probably be higher for the RNA. You're actually putting a piece of an RNA and putting it into your body. So you're transcribing and you're amplifying it to many more protein molecules and a lot of more epitopes.
Yeah, it's going to be like it gets in your cell, makes 1,000 of them.
You're like a factory making all those.
But efficacy is about mild illness, not efficacy based on whether it will keep you from dying or going to the hospital. So all the vaccines will keep you from dying or going to the hospital. What we're talking about with these efficacy numbers for the common consumer is whether or not these will keep you from getting mild illness. And really, when they throw these out there in the news and in the media, we shouldn't be worried about whether or not COVID gives you a mild illness, because we should be concerned whether COVID is going to get you in the hospital or make you die. So the first shot you can get is the one you should get, the first one that's available to you, because these variants are very dangerous.
And it's probably one of the most important points made tonight. Thank you for saying that, Victoria.
Very wise, lady.
Okay, Debbie, do you have more questions for us? Oh, I'm sorry, Dave.
No, as I say, there was a question which I thought was interesting for the neurologist I was looking through, which is about stimulants for the brain fog, Adderall, Vigil. What does Sheila think about that? Because I'm seeing brain fog all the time now.
Absolutely, absolutely. But again, you're treating the symptoms. You're not addressing the core, and that to get back to where you were. Doing some challenging, intellectually, stimulating exercises would help. But to get by your day, absolutely, there's a role for any stimulant actually to get by.
Okay.
Long term, probably you should build your core. Like you should get back to what you were by, resorting to these kind of, intellectually challenging exercises. There is also some few studies on that, whether coenzyme Q is known to help as well. People have been using some turmeric. But
turmeric, that's the one. I had a brain. I couldn't think. I'm taking some turmeric.
Turmeric has this curcumin, which actually enhances the dendritic connections. So the component in turmeric is basically curcumin, and they've done a lot of studies on that.
It didn't help me tonight.
You did?
But you should have caught me last night. My turmeric was on, babes.
That's awesome. Okay, Debbie, you want to?
Sorry.
While we're talking about the neurological effects, we had a question earlier about where people can find information about like peer-reviewed studies or anything like that about the mechanism surrounding this. Do you guys have any insight with that?
I mean, I would do personally. I've been reading Chest, and also The Lancet has quite a few good articles. A lot of them are not peer reviewed, but they've been small studies. But I know The Lancet is one that I use for a lot of the neurological stuff I've read and just long haul syndrome in general. And they've looked at about 1,700 people with long haul COVID symptoms. So I thought that was a good enough powered study, given that we're just only 1 year out. So, but Shaila, you might want to suggest another.
Yeah, there's a, I don't remember exactly what month it is, but there's a New England Journal of Medicine, which actually kind of summarizes the whole thing. And there's also one Italian study, which they actually did earlier. I think it was 179 patients. And they followed up to about 6 months with the long haul syndrome symptoms. That's a good one too, but I'm sure there are so many case studies, a lot, and dime a dozen.
Mm-hmm.
But I think these two strike me as a New England Journal of Medicine. I forget which one. I think it's probably in November or December, I think.
And I think you just type in the keywords long haul syndrome, and there'll be at least a dozen various journals. Yeah. Okay, Debbie.
Okay, so this question is a combination question of my personal and someone else's as well. So you were speaking about before, like your theories as to why people are more affected versus not. And someone was wondering if one of those things could be if there's like a certain threshold that some people are closer to versus not. And so the question is, if they already have a neurological disorder or some other disorder that causes excessive fatigue, are they more likely to have long haul syndrome after COVID, or any other symptoms for that matter?
Shaila?
Yeah, I can take that. So if you're talking about neurological disorders, like if you have, for instance, multiple sclerosis, you know, you're going to your reaction is going to be much more amplified. Your fatigue is going to be amplified there. But if you talk about say a migraine headache, it probably would be. This particular virus it's neurotropic. The neurotropism, it has a propensity to go and attack the the nerve endings, the dendrites particularly. So that's how you get the the mental fogginess. As far as the other symptoms, like other diseases, like if you look at any kind of an, if you look at myasthenia gravis, which are all autoimmune disease, or if you look at any kind of an epilepsies which have an autoimmune based etiology, yeah, they're going to mount a much more severe effect, actually, more than other conditions. That's because they have this innate immunosuppressive kind of a thing. They can't fight the virus, so it wreaks a lot of havoc on their system, and they would manifest with much more severe symptoms, including fatigue.
Thank you. Hey, Deb.
One more question about, long haul syndrome and, all the other effects, we talked about before, especially with the stories about this hypercoagulable state. Are there going to be more patients discharged on like short-term anticoagulation because just in case something like this happens, or is it too high of a risk to put them on this intense bleeding?
I think that we are using anticoagulation in patients that are higher risk, right? So patients that are hospitalized, especially in the intensive care unit, they're being discharged with anticoagulation. The question becomes, what about that patient that is being quarantined at home during that period of time, right? So those patients that are not necessarily as sick initially, we don't have any clear path in terms of prescribing anticoagulation, but I think at least aspirin for those patients in an outpatient setting during that acute phase may be kind of how we practice, and reserving the anticoagulation for the more ill patients that are hospitalized.
Right, and I completely agree with what Troy said, and we are definitely discharging folks from the hospital on a couple of weeks of blood, so it's not long term. It's just a couple of weeks, unless they, like Victoria, develop actual blood clots in the lungs, and then in that situation, we would treat them the same way we would treat anyone else with blood clots, with or without COVID, is we would treat for at least 3, sometimes 6 months of full blood thinner treatment.
I want to throw something out there for the diverse populations. I have the privilege of working sometimes with the Mercer County Health Department, and there's a whole population of people who do have severe COVID, and by severe, symptoms lasting more than 10 days, and not hospitalized because either they have no insurance or they don't have the ability to even recognize that this is not normal because they have no primary care provider. And these people don't even know that these side effects are a possibility. And they're not getting this type of information or direction. And a lot of them are really suffering some of these long haul symptoms and not able to pinpoint why. Or they say, yeah, I had COVID, but I recovered, but I still have a headache. Or I had COVID, but I recovered, but now, look at my leg. They don't understand that these things can be related. And because they had no care, because they were quarantined during their illness, they're not getting anticoagulants and they're not getting any kind of care because they did the right thing and they stayed home for the whole 14 days or the whole 3 weeks. So I think there's a whole segment of the population out there that is not getting any care for these type of symptoms.
Absolutely, thank you for pointing that out. It's a really good point. And Debbie, I'm just keeping track of the time. It's 8:19, and I'm just amazed that people are still holding on, and I'm very appreciative, especially to our panelists. Thank you so much. Maybe we have time for a couple of more questions, Debbie, and then we could try to wrap it up.
Sounds good. There's a few more questions. While we were on the topic about, African Americans not, the disparities that are there. There was a question that said, is it true that more African Americans are dying because their oxygen levels are appearing as though they are higher than they actually are?
I don't think so. But well, a lot of times when we have people in the hospital, it's already because they establish that they're very short of breath, or they're having severe symptoms that cannot be managed at home. But we are definitely finding that in the Hispanic and African American population, we are noticing that there are more severe complications, and there are definitely more deaths in that population. And again, there could be a lot of theories about that too, whether it's access to health care, or again, what Troy was talking about before, about the trust in hospitals and physicians, and kind of having experiences going, and I know Victoria can attest to this, where they go into the emergency room and they kind of played in their head, almost preview what's going to happen if I enter an emergency room now. Am I going to be turned away? Let me just kind of sit on these symptoms a few more days. I'm really not sure, but we are definitely seeing, whether it's genetics, but we definitely see a disparity in the complication rate. And if Victoria, if you want to talk to that.
Yeah, I would have mentioned to that, because when I had to put together my thoughts together, my daughter helped me, and my daughter's a nurse as well. So some of it I didn't have good recollection of because I wasn't awake. And one of the things I didn't have a good recollection of was the day I went back to the hospital because of my PE, because they had to go by ambulance. So when I said that I asked to go by ambulance, she said, no, you didn't want to go. And I said, yeah, I did. And she said, well, because I was kind of in and out, I was saying, no, I didn't want my husband to take me. I wanted to go by ambulance. They thought I was saying I didn't want to go. But the point is, the ambulance came And she told me tonight that the ambulance did not want to take me to the hospital. And I said, what? And she said, yeah, they didn't want to take you. And I said, well, I was having a PE. Of course they wanted to take me. She says, no, I had to make them take you to the hospital because when they came, even though I had fell out and my oxygen came back up, it came back up to 96. So when they came, my oxygen level was 96. My chest was pounding, it hurt so much. My husband was holding it. They felt my vitals were stable. I didn't need to go to the hospital. She made them take me halfway to the hospital. My vitals crashed and then came back up again, and they had to bring me into the ER. But I think that it's true that there is something that sometimes doesn't compute with the SpO2. And sometimes there are things that don't compute with the vitals, because I did not know that they told my husband they were going to leave me home. And my daughter, she's very petite and small, and she told them they had to take me to the hospital. And she never mentioned it till today.
I'm just horrified. It's 2021, 2020, whatever year, doesn't matter. Thank you for sharing that, Victoria. I want to bring attention to a question that came up relating to what Victoria said about having a blood clot after her vaccine, because she did have a blood clot in her lungs when she was diagnosed with COVID, and then again, incidentally or not, within a week after her vaccine. And just to answer everyone's question, because I know this is coming up, where there's a lot of stuff out there about the AstraZeneca vaccine and clotting, and people are worried that there's more clot formation after the vaccine. One, that has definitely not been proven that the vaccine causes clots. And second, if I may share which vaccine you took. Okay, you took the Moderna vaccine. So it was not AstraZeneca. I mean, none of us have had access to AstraZeneca anyway. And that's the one that has been kind of spotlighted that might be associated with it. However, this goes back to what we're talking about, and what Debbie was asking us, is there somebody who is literally at the border of like predisposed to getting this long haul or getting, I think, and in Victoria's case, and honestly, you're the only, and I'm sorry, but you're the only patient I know who developed a blood clot after the vaccine. And to date, we have millions and millions and millions of people who've gotten the vaccine, and this hasn't been reported. But I think because you had a blood clot already, and you have that predisposition to having a blood clot, this is just my theory, and I've discussed this with you, your blood may be at the threshold, and you even told me you could feel it sometimes where your blood is getting a little thicker and thinner, and I think if anyone was going to have one, it's someone who had a blood clot before is more likely to have a blood clot again. The other possibility is the vaccine does create this inflammatory response, which it's supposed to in order to develop immunity, but possibly it increases what's called the hypercoagulability, the clotting formation, and that might have happened, but it clearly doesn't happen commonly. Otherwise, we would have 80 million people with blood clots after their vaccines, and we certainly do not. So I hope that reassures.
I also people don't realize when it happens. Like it took a week. I know because I'm watching my body, but I also think that it's definitely some sort of an inflammatory response. And not everyone has an inflammatory response. Like obviously mine went crazy. I still would get vaccinated though, because I never ever want to have COVID again, ever. Just not worth it. But I do realize that I had some sort of inflammatory response to the vaccination, but I wouldn't want to keep anyone from getting vaccinated because getting COVID was way worse.
Mm-hmm. And I'm really, really, really glad you've said that, because I think that's the takeaway, is no matter what potential side effects or so that we can get from vaccines, which there really aren't many and there aren't serious ones, the COVID infection clearly is far worse than any potential side effects we can get from this vaccine, as we've seen in the last 5-6 months. All right, now, Debbie, I'm going to put the pressure on you to pick the very last question, so make it good.
I've been saving this one. So this last question, what about your experience or recovery from COVID-19 has made you the most grateful?
Yeah, I love that question. Troy, you want to start?
What about my experience recovery? I think that I'm just most grateful, kind of being, a religious person that, God has graced me to, continue to be here and deliver the gift of practicing medicine and be with my family. When you're lying in a hospital bed, not sure if you will ever see anybody again, that's an eye-opening experience, and to be grateful that you're still functional when others haven't been, and to be able to appreciate life is very rewarding. One of the things if I could just add that I had a chance to experience, so along those lines, I think about, when you're at a funeral, right, and you hear, people, speak about the person in the casket. After my experience, it was so humbling, not just colleagues, not just family, but the number of patients that reached out to me, and gratitude of how I touched their life was very humbling.
I love that. Victoria, what are you grateful about during this journey?
So I've been married 28 years, and my husband was absolutely wonderful during this entire ordeal. I scared him to death, but he was amazing. There were times in the hospital where I couldn't get a nurse, and he would call the nurse station for me. My mom, my sister, my kids, they rallied around me like no one's business. There was nothing. They gave me a diva card, my girlfriends did. So if I called, I could get what I wanted. My family, my support system was top notch. And having that, my congregation, everything about my support system was just phenomenal. And it makes you realize what you have. I didn't feel isolated. I didn't feel alone. I had so much love, and that was great. It made everything okay. I knew everything was fine at home, and I just had one job. That was to get better. That was
Awesome.
great.
Awesome. Thank you. And Dave, what are you most grateful about?
So it's pretty fun. It's not funny, but sometime in like April, when we were both, my wife and I were going to be alive, because we weren't sure in March. My one friend, Jimmy Johnson, organized one of those car caravans, and like 50 carloads of patients and family members and friends, they drove by with beeping, and the two of us were standing in the yard together, and we were just weeping. And it was such an amazing experience. I mean, the tears are just running down. I'm getting chills just thinking about it, that you take for granted these people who were in your life. And then they took for granted I was in their life, and all of a sudden we might not be. And it was very much this feeling of love in the air. It was a great experience. And I try to take that empathy when I see people, because I'm still seeing them. Look, I had 3 today, brand new COVID cases. And I have that empathy knowing where it could go. And I think it's made me a better physician, because I really feel for where they might end up. And I do everything I can to prevent that for them. And my own health, I definitely, I'm 35 pounds lighter. I'm eating better. I exercise more. I take my medicine that I used to ignore sometimes, and trying to do things that I know it cut me back. I have to kind of fight to get back to a position where I was taking for granted in the past. So I take things less for granted and I appreciate people more. If I have anything. It's a good
That was
thing. So in that
beautiful.
respect, it made me a better person. Thank you.
Thank you to all three of you. You're just, your stories are still touch me to this day. And I know people in our audience are very, very grateful for everything that you're doing. And you're helping, again, more than you know. I know this is closure for you and support for you, but you're actually helping others so much. And I think that should make you feel so wonderful as well. I want to transition to Gail, who will close us out from this wonderful webinar. Thank you again, everybody.
Thank you, everybody.
Gail?
Thank you so much, Ashgan, Dr. Elshinawy. Thank you. Hi, I'm Gail Foreman, the Senior Director for Advancement for the Stratford campus, and I want to thank everyone for attending this evening's webinar, and we hope that this session was helpful and provides some guidance for you, as well as for those that you may be caring for. It is devastating to know the damage that this virus has left in its wake. We hope tonight's session helps to shed some light on the post-COVID-19 experiences of so many. Please note that the recording of the session will be posted on our RowanSOM alumni page by next week. A very special thank you to Dr. Elshinawy, Dr. Bollard, Dr. Randall, Dr. Bokkala-Pinninti, and Ms. Fredrick, as well as student Dr. Meskin, for your time, for sharing your personal stories and struggles, and for your expertise on this important topic. Many thanks to our Alumni Webinar Advisory Committee, as well as our SOM Alumni Engagement and Advancement teams for their many contributions. The Webinar Advisory Committee is working on timely and important health topic areas for programs for the rest of this year, and you can suggest topics that you'd like to hear discussed through the post-event registration survey that you will receive shortly. In addition, the alumni webinars will move to a new quarterly schedule with our next webinar scheduled for June. Please check your emails for more information about the next webinar. I want to close by sharing with you that we are in the midst of our annual Rowan Gives event, which kicked off yesterday and closes tomorrow. This is Rowan University's annual giving event, promoting many programs across all campuses. The link is listed on the slide and was shared in the chat. Gifts of all sizes are appreciated, and there are many funds to choose from on the giving link to which you can make a gift. No gift is too small or too big, and your gifts will help support programs such as this one tonight. On behalf of the medical school and the Alumni Association, a huge final thanks to our outstanding panel and to all of you for your support and participation. Please stay well and have a good night. Thank you.
Thank you. Good night, everybody. Be safe.
Good night, everyone.
Bye.